Well, I'm Dr. Jim Del Rosso, the clinical editor in chief of the Journal of Clinical and Aesthetic Dermatology, the JCAD, and I'm here to bring you a summary of the April 2025 issue. And I have all the articles in front of me, and I just want to go over some highlights. So, one article that I think is very important is by Dr. Valerie Callender and colleagues, many well-known names in acne, in the field of acne. Efficacy and safety of a fixed dose clindamycin phosphate 1.2%, adapalene 0.15%, benzoyl peroxide 3.1% gel in Black participants with moderate to severe acne. So what they did is they looked at two phase 2 and two phase 3 studies, and they looked at patients that self-proclaimed themselves to be Black or African American, and in a little over 1,100 patients, they found that 14% of them were actually Black or African American, which equates very close to the general population. So that was very good to see. And the idea was to see the efficacy, safety, tolerability, and the characteristics of the patterns of response in Black and African American patients that were treated in these clinical trials. Now, this is a triple combination gel. It's the first topical agent FDA approved for acne that has three active ingredients in the same formulation, in the same tube. It is formulated in a polymeric emulsion that partitions the different ingredients so that they're stable, that you maximize penetration and tolerability. And that's a very well-known formulation type that's used in a variety of different products that come to us from Bausch Health. This is Cabtrio, which comes to us from Ortho Dermatologics, which is within Bausch Health. So when they looked at this particular agent, we know that the three agents, the clindamycin, adapalene, and benzoyl peroxide, outperformed in comparison in phase 2 trials the dyads, meaning it might have been the clindamycin and adapalene, clindamycin and benzoyl peroxide and adapalene were looked at individually. And the clinical response and even the tolerability really showed that the triple combination gel was favorable in terms of tolerability, but was superior in efficacy, both by global assessment and lesion reductions. So in this post hoc analysis, in these individuals with darker skin, specifically Black and African American patients, they could go down to age 9 years of age. And in these studies, in this particular company, they use the Evaluator Global Severity Score. That's the same as an IGA score. And they looked at patients getting to clear or almost clear with at least a 2-grade improvement. And they looked at inflammatory and non-inflammatory lesion reductions. And they showed that the results were essentially what had been seen across the trials with the larger group of patients, especially when you look at the phase 3 studies. What we saw in terms of global assessments and lesion reductions was the highest we've ever seen quickly within the first 4 weeks, and then throughout the duration of the study, not head to head, but the best numbers we've ever seen with any topical acne product. And that was consistent in the Black and African American patients. There are some very nice photographs that you can look at. And what was interesting is that patients that had hyperpigmentation by the end of the study, it didn't worsen, and in many patients improved as compared to the baseline. So I think this is a very good study that looks specifically at patients with that background and that skin color. Another paper that I think is really important that comes to us from Roger Seeley and his group. And Roger is a special section editor on surgical tips. And I think he presents a very short, meaning it's succinct, but thorough assessment on how to protect patients and position patients so that they have the best experience, a comfortable experience for the patient and also for the surgeon. So he gives some tips on that. But the reason why I asked him to do this is I saw him present on surgical tips one time, and he came up with this concept of the no-fly zone. And it's such a simple concept. And I could think of many times that instruments or biopsy bottles with formalin or whatever liquids are passed over the patient's face area. Their eyes may be closed, but if something is dropped or spilled, even an instrument, it could certainly harm the individual's eye or face. So the no-fly zone, there's a nice picture in the article, and it basically is the area above the eyebrows, goes outside the lateral portion of the orbital areas, and then down below the eyelids. For me, it's the whole facial area. Um, I've expanded it in when I've used the no-fly zone, but nothing gets passed across that area. Just like airplanes are not allowed to fly in certain areas. I think that's a great tip. And he's the only person I've ever heard talk about that. And I worked with a lot of different great dermatologic surgeons over the years. And I've not seen the no-fly zone carried out consistently, as Roger explains. And I know he does in his practice. The third paper is the treatment of recalcitrant Haley-Haley disease with dupilumab, a case report, and the lead author is Carolyn Sulish Moore, a dermatology nurse practitioner, nurse practitioner who's certified, who works with David Altman in Warren, Michigan. David is a special section editor who has also submitted some previous case reports, and this is a very interesting case report. Stuart Gildenberg is also one of the authors, a dermatologist. So this is a case of a 34-year-old female with a 15-year history of Haley-Haley disease, which is very diffuse, not only under the breast and axilla, but diffusely on the trunk and back, and also on the popliteal area, which became so inflamed and eroded that the patient couldn't move it, and they developed a deep venous thrombosis behind that popliteal fossa, primarily because they had so much difficulty moving their leg because it was so painful. There are excellent photographs at baseline, which shows you how extensive the Haley-Haley disease is. We know this is an erosive and vesicular bullous disease, an inherited disorder, and we really have not had a lot of therapies that have been consistently helpful. This patient went through a plethora of topical treatments, topical corticosteroids, antifungal agents, tazarotene, mupirocin, and various rounds of systemic therapy, including antibiotics like amoxicillin clavulanate, cephalexin, even dapsone and minocycline, some glycopyrrolate, oral apremilast, naltrexone, prednisone, nicotinamide, and magnesium. Some were used concurrently and some were used sequentially. And there really wasn't a lot of improvement. Very, very frustrating, obviously, for the patient and for the clinician. And then, based on some case reports and mentions that we've seen in the literature, this group, Dr. Altman's group, decided to initiate dupilumab. Dupilumab, we know, is an injectable monoclonal antibody that inhibits interleukin 4 and interleukin 13, but it's also been shown to modulate calcium transport. And that's believed to be a mechanism in Haley-Haley disease and also has been talked about in Darier's disease. And there are some examples. That's an acantholytic disease, an inherited disease. That's a situation where dupilumab and even tralokinumab have been shown to be helpful. But in this case, we're talking about Haley-Haley disease. What was noticed is the patient received the 600 milligram loading dose, followed by 300 milligrams every 2 weeks, the standard dosing with dupilumab. And by 2 months, saw significant improvement. And then by 4 months, dramatic improvement. It really is worth looking at this and looking at the photographs. Extremely impressive. This is a great case report, and you can go to PubMed and look at other publications that have been reported with dupilumab, and some of those are in the references. So I want to go on to a couple of other papers. I'll go over them succinctly. There are two that relate to 10% aminolevulinic acid gel with photodynamic therapy. That's red light photodynamic therapy. And there were two papers. One is by Gary Goldenberg and colleagues from New York, where he looked at red light photodynamic therapy with microneedling done to help increase the penetration of the 10% aminolevulinic acid for patients that had facial actinic keratoses. And it's a small pilot study. They state that the limitation, it was a small number of patients, 5 patients, where they went through the degreasing and to remove, grease and debris on the face, applying the 10% of, of aminolevulinic acid gel, 4 pea sizes on the face, and then microneedling one pass, going anywhere from zero point 0.8 to 1 millimeter into the skin, and then reapplying the rest of the aminolevulinic acid gel, the 10% gel, incubating for 30 minutes and without occlusion, and then having the patient undergo their red light exposure. And what they showed was they showed good results in terms of the actual cosmetic appearance. They utilize a global aesthetic score to assess from baseline. And in the photographs that they show here, you're looking at that baseline in 8 weeks. There are a couple of photographs that are shown that are very nice in the publication. They also showed that discomfort was reasonably well controlled in most of the patients, and they had a significant reduction in actinic keratosis lesions. So microneedling may help in the delivery of the aminolevulinic acid. And then Joel Cohen, this is an open label multi-center study with Dr. Joel Cohen from the Denver area as the lead author, but there are several investigators here. I see several names that I know, like Bill Hankey and Natalie Zatoni and Todd Schlesinger, and also many others that do photodynamic therapy. And this was to look at the safety and tolerability of 10% aminolevulinic acid gel over an expanded field. So they could have actinic keratoses on the face and or scalp. The mean number of lesions was about 17 over 60 centimeters squared. So it's a much larger field treatment, not just lesion directed treatment, than what had typically in most cases been talked about and utilized in the past. And so treating an expanded field, when they looked at this, they showed that yes, you always have to be looking at ways to minimize pain, but the significant increase in the area did not have a significant increase in the pain. There was some increase in pain because you're treating a much larger area, but they were impressed with the fact that it was less than one would anticipate, and most patients did very well and tolerated the treatment. I think both of these papers are worthwhile if you're utilizing photodynamic therapy and utilizing the 10% aminolevulinic acid gel and red light, that you look at these papers to look at the methodologies of what these individuals did. And I'll just mention 4 of the papers. So I'm not going to go through them in much detail, but Sana Kambaj and Travis Blaylock, they reported on race reporting in dermabrasion clinical trials, a systematic review. And they looked at the literature, at studies with dermabrasion or reports with dermabrasion, and found that less than half, 46% of the studies mentioned race, skin color, or Fitzpatrick skin type. And I was very, very surprised about that because I think if you're doing a dermabrasion, that's an extremely important consideration. So that's a very interesting paper. And they talk about the limitations of not having enough reporting of the skin color, the skin type, and the race of the patients, especially with a procedure like dermabrasion. A couple of the other articles, we have Rami Mahmoud and others, a very extensive review, comprehensive review of exosomes for the practicing dermatologist. So if you feel you don't know enough about exosomes, they're used a lot in cosmetic formulations and even some other formulations and delivery systems for topical delivery, typically. And this is very thorough. If you're wanting to learn more, I suggest this paper. I certainly don't know enough about exosomes, and I found the paper very helpful. Another paper was, what does it mean to be beautiful? Well, I don't have a problem with that, but for those people that have some concern about how we assess beauty, and believe me, I could use some help in that department too. But in this paper, exploring the limits of AI, artificial intelligence driven beauty assessment. And it seems like it might be a little bit out there, but it's not. Many people are going to artificial intelligence and utilizing that to tweak their pictures. I know some colleagues and individuals I know, I see their pictures posted and I go, wow, that's a great picture, an interesting picture. And they'll tell me, oh, I tweaked it with artificial intelligence. So obviously people are thinking about this and doing this, but how we are going to adapt to utilize artificial intelligence for beauty assessment and how it may impact the delivery of clinical services and the perceptions that patients have.
Yeah.
This is a final paper, which is an evaluation of a dermocosmetic serum containing a multi-acid complex and niacinamide in Japanese women with mild acne. There were 46 out of the 50 women who completed the trial. Just four patients developed some irritation from the product, which was did not need any intervention and it typically went away. They had up to 20 lesions. They had mild acne. These were women in Japan that were between the ages of 16 to 34 years. And this is a specific formulation that contains niacinamide 2%, lactic acid 1%, hydroxyethylpiperazine, ethane sulfuric acid. That's a new one, 0.5%. I think that's projected to be one of the secret sauce ingredients in the formulation. Phytic acid, 0.2%, and salicylic acid, 0.2% from the Roche-Posay. And this goes through the utilization of this product twice a day in patients assessed over an 8-week period and what the results were. So that's my summary of each of the articles. Once again, I think we're bringing you a spectrum of clinically relevant articles, and we plan to bring you more. Let us know what you think at JCAD, and we'll keep bringing you the best that we can. Thank you very much.